Okay. Okay, let's start talking about the rapid reporting section. I will share my screen. First, I will talk about some of the important books for the rapid reporting section. I told you many times before about this short PDF. I made it, and there is a lecture for this PDF on YouTube in the Eagle Eye playlist in our channel. The RR checklist, the rapid reporting checklist. I keep telling everybody about this PDF and about this lecture because it is very, very, very important. And you have to make your own checklist, or you can use this freely, but you have to memorize it in the same steps, in the same manner. Also, there is a general rules for the exam. You have to stick to these general rules because if you missed one of these rules, you probably will miss a case in the exam. Write only definite abnormalities. The positive ones are for sure positive. The query ones most of time are normal. The answer pattern also is important that you put the answer for all the cases in the same pattern, starting by the side, right or left, the exact site of the abnormality, and the sort. What is the type of the abnormality? Is it a mass? Is it fracture, dislocation, and else? Everything else. Each view has its own checklist. So in shoulder, as example, in shoulder X-ray, you have 4 or 5 views for the shoulder, and each view of them has its own appearance, its own characteristics, and also has its own checklist. So, for example, the shoulder you have AP view and the glenohumeral view. The AP view has normally has overlap between the humeral head and the glenoid, but the glenohumeral view normally has no overlap. See the difference? So in the AP view, your sign for the dislocation is loss of the overlap, but in the glenohumeral view, normally there is no overlap, so it is not a sure sign for dislocation in the glenohumeral view. So please don't mix between the views and between the checklists for each view. Also, each age has its own checklist. In the pediatric age group, there is certain fractures that could happen, but not in the adult, and vice versa also. Don't forget to look at the edge of the film. But if you find the abnormality at the edge of the film, it has to be a very clear abnormality, 100% sure that it is abnormal. Okay? Also, don't forget that for January, I think I don't know they will change the rapid reporting scheme in the exam or not yet. But in January, for sure, it will continue like before. So the checklist for rapid reporting is different from the Viva. The Viva has more subtle finding, more findings for discussion, for further assessment by other modalities. But in rapid reporting, you don't have this opportunity. You don't have, there is no discussion, there is no further assessment, there is no prior images. So the abnormality should be 100% sure in this particular X-ray, in this particular view, without assuming anything, without imagine anything not there, or without need to clarify or to discuss the abnormality. The abnormality is fracture. No need for discussion for it. Okay. Also, don't over zoom because over zooming will show the normal trabecular pattern as fractures. Sometimes the venous channels as fractures. Number of no, it is not fixed. The number of cases is not fixed. Um, from 14 to 16, this was the 14 normal, 16 abnormal, sometimes 15 15, sometimes 13 17. I think you care about numbers only if you feel that you put 20 abnormalities. So now you probably make some overcalls. You care only about the numbers when you are overshooting or undershooting. So you care about it. But in the normal range, I think don't care much about the number of the abnormalities. Okay, you have to do it very fast. As I told you, you have to solve the exam at least on in 15 or 20 minutes, because in the real exam situation you will be exhausted after the long. Your concentration will not be optimum. And other, the stress and long nights before the exam, without adequate sleep, and all of these factors will make will make your performance in the real exam a little bit lower than your usual performance or normal performance. So train hard on doing things very fast, and you already memorized the checklist and the how to look through the images. So in your subconscious level you are good to go. Okay, choose your answers from the RR answer box only. That this is like don't put abnormalities that needs further assessment or needs other images or needs some discussion. This is for the Viva situation. But in the rapid situation, only put the clear ones that doesn't need anything else other than the images in front of you. The last one is be a robot. There is no place for feelings that you feel it is not normal. You feel you are not sure it is normal or what is the abnormality. Uh, you are searching for signs. If you find a sign, so it is abnormal. If you didn't find a sign, so it is normal, and that's it. Okay, and please go through the this PDF every day. It will take from you 5 minutes daily to memorize the views, and each view what is the abnormalities that could come in this view. And don't forget, don't mess up. See, this is the occipital mental. There is checklist in it. The AP, the normal AP. Okay, I will put it in the Telegram group. For the AP, there is another checklist, and see the difference between both of them. In the orthopantogram, there is a checklist. In the lateral, there is another checklist. See, so please do it on daily basis. Okay, let's go through some of the important books of the X-rays also. I will tell you how I was doing it during my preparation for the exam. As example for let's start by this accident and emergency. It is a very important book. For me, while I was preparing, I was going through the book only on images. Most of time I don't read all of this stuff unless or except if I don't know the image or I don't know this piece of information, so I will read it briefly. But most of time I am going through the images only to train my eyes to see as much as I can for the X-rays, and that's it. Most of time I'm doing it like that. And also, I put a lot of tips from this book in the Eagle Eye videos. Another book also is important, and I think most of you don't know it. This abdominal X-ray for medical students, because the for myself, I feel I was weak a little bit in the abdominal X-rays. I don't see many abdominal X-rays in my work, and even in the exams, there is no many abdominal X-rays. So I read this book specifically for the abdominal X-rays, and each one of you has his own weaknesses, and each one of you must search for what areas I am weak in to solidify it, or to read something or watch a video on it or train more on it. You must search for your own weakness points. Okay, this abdominal X-ray was nice that he brings first the abnormal, the normals, and what's the difference between the air, the fat, the soft tissues, the densities. So you are training your eyes on how to differentiate between the different densities. And it is important specifically in the abdominal X-ray because sometimes you don't know this is a pneumoretroperitoneum or this is the normal fat planes. So you have to train your eyes and see as much as you can for the images. This book also was so nice, and see the I bring some images from this book also in the eagle eye videos. There is a specific eagle eye video for the abdomen. Please also try to watch it. Okay, and again, I am only looking for the images. See, this is a fat. This is the density of the fat planes, not the density of air. The air is more black. The fat plane is more gray. Always train your eyes. Okay, and I don't have to read all this information. I only train my eyes on the images, so I can see. I can finish a book per day, 100 pages per day, because I am not reading every single information in the book. If I want to read something specifically, I will read it, but most of time I am not doing that. Okay. Also, another book is important. I think you know it. This is the same team, I think, for the accident and emergency. Make this chest X-ray survival guide, and this is nice book also. I used it many times for preparation for the eagle eye chest video because he brings first the normals, the anatomy, and then take abnormality one by one. How you will see the collapse, how you will see the consolidation, how you will see the mass. What about the skeleton? And that's it. He brings different views because I told you before, the difference between the views equals the difference between the checklists. See, this is the normal EP view. You can see a small long apex above the clavicle on medial end, but in the AP lordotic view, you will not see a long apex above the clavicle, but you can see the sternum. The manubrium here is a little bit widened, and you can see the first the junction between the sternum and the first rib. You can see it here, but you cannot see it here. If you see in the AP view whitish opacity on paratracheal side or in the lung apex, so it is probably a mass. But in this lordotic view, it is normally there is some opacification on the apices, on the lung apices, because of the manubrium. Now the manubrium now is looked bigger than this view. So this is the point. You have to look for the view, which view is that, and according to that, you will change the checklist and you will change the signs. You are searching for signs. Don't forget this. You are searching for signs. Okay. Also, another book is very nice for the fractures, for the bony fractures, imaging, musculoskeletal trauma, interpretation, and reporting. Okay. Again, I see. I am looking for the images. I am training my eyes on the images. If there is a weird image or a fracture that I have never seen before, so I will read briefly the description. But if I saw the abnormality, so that's it. It is easier to go through many images in a very short period of time. Okay. Also, one of the very important books, and you have to solve it, all of you, this pediatric radiology rapid reporting book. I think it has 7 exams or 7 or 10. Yeah, it has 10 exams. But really, they are very important because the pediatric age group is very unique and has very unique science and has abnormalities that will not come in the adult age group. And most of time, in most of our practice, if you are not working in a children hospital or near a children hospital, you will see a little few images from pediatric side. So Also give it more attention. As I told you, each one of us has his own weaknesses, has his own problems. So try to solve your own problems and try to tailor your preparation according to your own weaknesses or own problems. And you can solve it in a Word file. You can open a Word file, or you can solve it by handwriting for each image, and then review the answers at the end. And please try also to take screenshots for your mistakes. So I solved today 3 or 4 exams, and I had around 5 or 6 mistakes. So I take screenshots for these 5 or 6 images that I made them wrong and put it in a separate folder, name it mistakes, name it revision or anything. And by on weekly basis or on monthly basis, I review this folder. It may contain 100, 200, no problem in that, because you are training, you are still learning, you are still preparing for the exam. Don't care about the marks, don't care about anything else other than training and picking your weaknesses and mistakes. Okay, let's stop share that and go for another section. This is the YouTube channel. There is a lot of videos, some of them in English only, some of them mixed Arabic and English. But this eagle eye is English only, and this is the video that I told you about the checklist. It is 45 minutes, or in Arabic version, it is 22, or at least review the PDF itself in 5 minutes every day. You saw the view, and each view, what is the checklist for it, and try to do the checklist in the same order, the same manner, the same approach. So you solve it, you memorize it by your heart. So even if you are not giving much concentration in the exam, or even if you are exhausted, your mind is already trained on this approach or in this manner. Okay. What else? This also rapid reporting exams from Radiopedia. I solved it, and you can see I solved it in very short period of time, even with discussion. So you can go through the videos and see how I solved these exams. Also, a very important or a nice tip, really, I use that sometimes, and I'm using it in the Eagle Eye course. Also, this Google Forms. You can do your some Google Forms for yourself. You can gather some of the hard films there, or you can make a small quiz for yourself. I know that I am weak in picking the pneumothorax. Okay, I will gather around 10 images of the pneumothorax with some mixed normals and try to solve it. Other friend has weakness in the knee or in the pelvis X-rays, so he will do 10 or 15 gather 10 or 15 images for the pelvis only and put it in a small quiz like that. And be active, make your preparation active, not this lazy thing. I am lying on the bed and only watching the video, or only solving the exams by my eyes. Don't be like that. You should prepare actively, you should solve, you should make your own notes, you should memorize things, you should put yourself in pressure or in a testing mode, so that you will know your mistakes, you will know your weakness points. Okay, don't forget that. Let's try to solve an exam. Let's take one of the exams here and see how we should go through the exam in one shot in 10 minutes or 15 minutes quickly, so that I am training to do the checklist or searching for the signs very quickly. Let's put the and in this approach, or in this style, I will not zoom. I will not change the window. I will not do anything. I will have a general look or a quick look in the image. If there is obvious abnormality, I will write it down. If there is no obvious abnormality, I will keep it blank, and then I will go back to it after the first run. So here, see my approach. If you love it, you can use it. If you have another approach, stick to it, but please apply it in the same manner, in the same order. So mine, I love to start by the edge of the film. So I will start by this tibia and fibula, and then the ankle joint, the neck of talus, the calcaneum, and then the tarsal bones, and then the metatarsals. Okay, and then the toes or the phalanges. Here I can see there is a acute angle in this neck of the metatarsal. Uh, so I will put it and then flag it that I need to review it in a close or in a zoomed view. But I will put it. There is no side marker here, so I will not put a side marker. But I will put the site, the exact site. It is a fourth meta tarsal neck, and the sort, the type of the abnormality is fracture. And I flagged it because I am a little bit doubt about it. I need to zoom it. Let's go to the next case. Also, for the chest X-ray, you have to have your own approach. My approach is different from yours. My weakness points is different from yours. See, I used to forget the retrocardiac region. Another one used to forget the lung apex. Another one used to forget the ribs. So my sincere advice is start by your weaknesses. So, I usually miss the retrocardiac, so I start by the retrocard. I usually miss the reps, so I will start by the reps, and then continue the checklist as you like. Do whatever you want. But for me, if there is no obvious abnormality, so I will start by the bones. I will start by the bones if there is no obvious mass or opacity or free air or something like that. So I will start by the bones, checking from the side of the image again if the acromioclavicular joint is included in the field of view. I will check it. The humeral head, as long as it is not under the coracoid process, so it is normal. Regardless the look of the humeral head, regardless the position of the humeral head, the sign for dislocation is the humeral head is under the coracoid process. So if it is not under the coracoid process, so it is normal. I told you there is no place for feelings. There is no place that I am not sure. No, you are searching for signs. If you caught a sign, so there is abnormality. If you didn't caught a sign, so there is no abnormality. Then I will check the clavicle, the scapula, and the right-sided ribs. Don't forget the posterior parts and the lateral parts. This is the most common sites of abnormality, especially the lower ribs. And then I will move to the other side. Again, the edge of the film, if it is included. The coracoid, there is nothing under it. The scapula, the rest of the clavicle, the ribs, posterior and the lateral, especially the lower ribs. And then the spine, if there is a shape in Viva also sometimes they bring extramedullary hematopoiesis or osteomyelitis, discitis osteomyelitis with paraspinal abscess formation or any of other diseases like that. And then after finishing the bones, I move to the lungs. See the lungs, make sure that you check the apices for pneumothoraces, the retrocardiac area, and the free air. You have three free air: pneumomediastinum, pneumothorax, pneumoperitoneum. Always check for them. Double check for the free air because it is usually subtle. This one is normal, so I will keep it blank and I will give it another try in the second run. If pediatric, I have to put Salter health type. In the rapid reporting exam, also don't put eponyms or classifications. Try not to put it in the rapid reporting because in the exam situation, sometimes when you are in a hurry or you are in a stress, you may mix between the types. You may miss between it is type 2 or type 3. You may miss between the eponyms like Galeazzi or Montigia. What is the fractured bone? What is the dislocated bone? And so better for me and better also for you. Try to avoid the eponyms or the classifications and describe only what you can see. If you can't find the radial head or neck fracture but elevated, so writing only, yeah, please keep these questions at the end of the session. Try to concentrate in this exam. In the elbow, you can put elbow joint effusion without detecting a fracture, but this is the elbow only. And the knee also, if there is lipoheme you can put it as a separate answer. Okay. See, this foot, I don't like it in this way. I used to see the foot in the other direction. This is in my normal practice, so I put it in the direction that I used to report it. Again, I start by the tibia fibula and the talus calcaneum, the tarsal bones, the metatarsals, and then the phalanges. I cannot see any abnormality here, so I will keep it blank also. See, this one is obvious here, so I will save some time and put it starting by side, then the exact side, then the abnormality. See, like that, or you can put this mark for fracture to solve more time. And I didn't put a flag because I am sure already about this abnormality. Here I used to see the cervical spine in this way, so I put it on the same manner that my eyes used to it. Here also I can see this is C1, C2, C3, C4, C5. You have to have approach for the cervical spine. My approach is to start by the anterior and posterior longitudinal lines and the spinolaminar lines, then check for the vertebral bodies itself if there is fractures, the prevertebral space, and finally don't forget the mandible. It is included in the field of view, so you have to check it. See, I can see here the facet dislocation, and you can see it is locked the facet. So I will put bilateral facet dislocation between which levels 2, 3, 4, 5, 6. So I will put it abnormal, and I will put bilateral C 5, 6 facet dislocation. So this is the side, this is the exact side, and this is the sort, this is the abnormality. And I keep it in the same order. Okay. Why bilateral? Because it is locked the facet. But we use better in the exam to use only unilateral and the bilateral. Don't use any other terms like Purchase facet or any other thing. Give me 1 second. So this tibia fibula, let's check from the edge of the film. I will take side by side. I will check the distal femur on the right side, then the epiphysis, then the tibia fibula, and the metaphysis and the foot, and then go back from the other side. And I cannot see any obvious abnormality, so I will keep it blank. Here, radius ulnar, and this is carpal bones and carpometacarpal joint, then the metacarpals, and then the phalanges. See? So quick look in 15 seconds or 20 seconds because you already know what you are searching for and you have the same approach for all the hand images. So you are doing the same thing in the same order every time, so you already saved it by your heart. This is the spine. Don't forget the lower ribs, then the spine. For the lateral, transverse processes, most of time there is overlapping shadows. So don't overcall it as fractures. And then don't forget the sacrum. You should see the sacral arcs, sacroiliac joints, and the soft tissues, the calcifications. Here is the pancreatic head. There is the pancreatic tail. See, this is the renal shadow, and this is the other renal shadow. So you will search for renal stones here. Ureteric stones have to be close to the transverse processes, so not mixing between the renal and the ureteric, because renal is not ureteric and vice versa. If you one time before, one of my friends put the answer as renal slash ureteric stone, and he lost the mark for this question. You have to put the exact site of the abnormality. Okay, so I didn't see anything. I kept it blank. And then the hand again, I will do the same. I will check the radius, ulna, the carpal bones, the carpometacarpal joint. You can see the zigzag black line here, the metacarpals, and then the phalanges. And also, I couldn't see any abnormality. I will keep it blank. The pelvis. The pelvis always don't forget that we have three types of pelvis. We have adult pelvis, we have adolescent pelvis, we have a pediatric pelvis. And each one of these types has also its own abnormalities and its own checklist. As example, for the pediatric, you will start searching for the SOFI, slipped upper femoral epiphysis, or Perthes disease, or DDH, and then do the rest of the checklist. In the adolescent, you will start by the avulsion fractures and then check for the other checklist. In the adult, you will start by a different thing, because with age there is different abnormalities. For me also, I love to start by the sacrum because I always miss the sacrum. So I start by the sacrum for sacral arcs, and then I go to the four rings. There is outer ring here, all of this, and then there is inner ring there, and there is two obturator rings, checking the superior and inferior pubic lemma. And then at the end, I check for the Shenton line. The Shenton line along the femoral shaft, neck, head, and the Shenton line on the other side, and see, I can see there is a fracture here. So we take some time because I am explaining to you, or I am discussing with you left neck of femur fracture, and make the answer simple as that, and never put it like that. There is no abbreviations accepted in the exam. Okay, and I will not put a flag because it is obvious for me. So this view, you can see the orbits clearly, and don't forget the orbital floor, the maxillary sinus, the zygoma, and if there is any part of the mandible included in the field of view, check for it. Here, don't put a dense fracture because first, it is not the dense view, the open mouth view. Second, you cannot be sure 100% that there is a fracture or not because there is many overlapping shadows. Also for the skull vault, some of the colleagues may put a fracture here or a lucent lesion there. You cannot be 100% sure about this because you can see the outer and the inner table. Yeah, there is multiple ill-defined lucences, but this is overlapping shadows. So take care of that. For me, I can see here a teardrop. For the orbital floor, you have to see a teardrop or a floor fracture through the bone. Okay, so I will put it like that, left orbital floor fracture. and there is assuring signs or associated signs like the maxillary joint, the maxillary sinus, hemosinus, or effusion. Sometimes you can see the black eyebrow sign. These are assuring signs that you picked a obvious abnormality or a true abnormality. Here I will go through the bones from the edge, as I told you, radius, ulna, and then the carpal bones. There is no dislocation or there is no tricuspidal fracture. And the metacarpals, especially the fifth metacarpal, is the shortest one. And the first carpal metacarpal joint has many different views. So train your eyes to see a lot of images. And this is normal also. See what kind of this pelvis. It is a pediatric pelvis. So I will check for the Perthes, the SOFI, and DDH first, and then I will go through the rest of the checklist. Also, there is no abnormality here. See the appearance of the inferior pubic rami is like that in this age group. It is different from the adult group. And don't forget to look for the abdomen also if there is any calcifications or masses or any other abnormalities. This is the humerus and the radius and the ulna, and here you can see what is called a buccal fracture or torus fracture, and this is so common in this child or in this age group, pediatric age group. So I will put it as left distal radius buccal fracture, side sort. See, I keep it like that for all the images. So I will never miss to put aside. One of our colleagues before get, I think, four in rapid, and she was very certain that she picked all the abnormality correctly, like her colleagues, but she remembered that she missed all the sides. She didn't put any side in her answers. So please train from now and make that your answer or your scheme do it in the same type or in the same order for everything now. So in the exam you will not miss it. You already know it or you already memorized it without thinking even. Okay. Here I can see a radio opaque shadow in the renal shadow in the lower pole. So I will put it left renal stone and that side sort. Okay. Stop annotating the screen, please. Here for the orthopantogram, please check for the cortex itself because you will see a lot of overlapping shadows. There is overlapping shadows here, there, everywhere. Please check for the underlying cortex. Is it intact or not? And this is the sign if there is a fracture or not. And the teeth are parallel. The socket, the ball is in the socket here and there. So there is nothing there, but I will keep it blank for another run. Here, this is also so common in this age group. And to be sure that it is a true abnormality or not, try to draw the vertebral body beside each other. If it is included in the soft tissue, so it is definitely widened. Okay? So, prevertebral swelling. Here for this knee, can see the femur, the patella, the tibia, the tibial spine, and the fibula. And also, again, don't mix between the tibial plateau and uh, the avulsion fracture, uh, the second fracture. Okay, the second level is a little bit below the tibial plateau level. Because, but also one of our colleagues put the answer like second slash tibial plateau fracture, and he lose mark for this case. So please don't put any slashes, dashes, or you are not examining the examiner. He is you are you are the one who is being examined. So please put certain answers, definite answers without any ambiguity. Okay. Again, I check the anterior, the posterior, the spinolaminar, check the vertebral bodies, spinous processes, prevertebral soft tissue, and the mandible. There is nothing there, so I will keep it blank. Okay, this one is so obvious, I will put it like that. Right, mi- middle, lung, zone, opacity. Again, the abdomen, check the lower ribs. If the lungs are included, also check it. The vertebral bodies, the pedicles on each side, and the pelvis is included. So please do it like the pelvis X-ray that starts by sacrum and then outer ring and then inner ring, two obturators and part of the central lines. Then the soft tissues, the calcifications, there is nothing here, and the bowel shadows are normal, so I will keep it blank also. Here we can check the orbits, the orbital floor, the maxillary sinuses, the zygoma, and the parts of the mandible which are included. I cannot see anything here, but in the skull I can see there is a lucent line there. It is not a suture. Also, train your eyes about the difference between the sutures and the fractures. Suture should be irregular and in anatomical positions. Fractures are not. You can see the fracture is very sharp and black. So I will put it like that. Right, supraorbital fracture. And I will go to the next one. The lateral knee, if it is a transtable view, so check for the lipoheme arthrosis, and you can put it as answer even without fractures. Okay, and this is the tibia, fibula, and the patella, and everything is okay. So I will go to the next case. See, each image may take around 20-30 seconds at most. Keep it like that because I'm not zooming, I'm not doing anything. I only search for the obvious abnormalities. Okay, this is the radius and the ulna. This is the carpal bones and the metacarpals, then the phalanges, and don't forget to check the physis because sometimes you consider the fracture as a physis if you go quickly through it, but the physis are at the basis. So if there is irregularity in the distal end or in any place other than the physis, it is definitely a fracture. The physis in the metacarpals near the heads, the physis of the phalanges near the bases. Uh, and this one I think will need some zooming. This one is so clear. See the coracoid process, you have the humeral head under it. So it is definite abnormality. It is a clear sign, right? Anterior, right shoulder, the same pattern. Anterior dislocation. So side sort. Here, you cannot see clearly the orbital floor, so don't overcall it. You cannot see clearly the zygoma, so don't overcall it. You can see the mandible. The mandible here is clear. You cannot see the dents very clear, so do not overcall. Okay? This one definitely will need zooming. And again, this is the spine, lower ribs, pedicles, sacrum, outer ring, inner ring, obturator rings, part of the Shenton line, the soft tissues shadows, and the bowel gases. They are also normal. Here, start by the edge, tibia fibula, posterior malleolus, talar neck, calcaneum, the anterior calcaneal process, the tarsal bones, the metatarsals, and there is something parallel, parallel to the shaft of the fifth metatarsal. So it is apophysis. It is not fracture. Here also is so obvious. You can see the diaphragm, and there is free air on both sides. So this one will be easy. Pneumoperitoneum. So unless I was explaining and describing what I'm doing, I would take this run in 10 minutes, 12 minutes, and see how many abnormalities, definite abnormalities you get. One, two, three, four, five, six, 7, 8, 9, 10, 11, 12 abnormalities. So you have at least 20 minutes, and you want only to find 3 or 4 more abnormalities to be on the safe side. See, so you should train yourself like that. Let's go back and start zooming for the images that we want to check more. See, so I was right here. You can see there is, it should be smooth. See this cortex, very smooth. But here, there is buckling. Even you can tell on the other, on the third also, and the second, you may include them, at least the third. And also in the exam, most of the time, they bring 2 views to add more clearance to the images. This one, I will zoom only for the apices because most of time we miss the pneumothorax. And what are the signs for pneumothorax? You have to see a visceral pleural line, and this line should be curved at the apex. Okay? See, this is the phalanges. Phalanges. See how the cortex is very smooth, not like the previous one. This a little bit longitudinal preosteal reaction. We are not afraid from it. It is normal. See, this is parallel to the mother bone, so it is normal also. Everything else is normal, so I will put it as normal. And then I will skip the ones I answered them clearly. And let's make a little bit some zooming here also. Side by side, if there is any spiral fractures or if there is any metaphyseal corner or buckling, then the other side, there is nothing, so I will put it normal. See the scaphoid, you have a lot of different shapes of scaphoid. Train your eyes on them. And this zigzag line is very clear, black one, there is nothing. And the distal tufts, they are normal. I think this is the same software with the Practique used in the real exam. It's also good to try one of these websites. So there is nothing. See, in the transverse processes, a lot of shadows, and always ignore them. See, I am doing it very smoothly, very quickly, because I know what I am searching for. There is nothing here or there. The metacarpals, and this is normal. One of the colleagues have a question about the, yeah, absent pedicle. Oh yeah, the first one. Perfect. So better to go to the exam with your friends. L1, right. Let's make it like that. Right. L1 pedicle. Okay. What else we have? This one 12. This is the radius ulna. There is no tracheotomy fractures. There is nothing here, so I will put it normal. This one, let's make some zooming for the calcifications, soft tissue calcifications. Sometimes they are masked by gases, but they could come in the exam. Okay, there is nothing in this side of the image. Let's check the other side of the image. So it is normal. Sorry. So what else we have? This one, 16. We'll make some zooming. There is nothing there. See, I'm checking the cortex. The cortex is intact. Nothing in the cortex, so I will put it normal. We'll make this. Let's try number 18. I will zoom here. There is no avulsion there. The tibial plateaus are smooth. The fibular neck, the patella, the femur, everything is normal. So I will put it normal. I will zoom the dents, the mandible, the vertebral bodies, the facets. See, the facets are so smooth. So I will put it normal. What else we have? I will zoom for the soft tissue calcifications. See there. See, this is the fat planes, how it looks like. The overlapping gaseous shadows, see, but the underlying cortex is intact. Sacral arcs, everything is clear, so I'll put it normal. What else we have? 23. Femur, here, fibula, tibia, everything was normal. So I will go to the other one. And Nemo peritoneum in the previous one. Let's go back. This one. What is the sign for pneumoperitoneum here? Hmm? What is the sign? Hmm. Let's make a little bit zoom. Here there is some irregularity. Here inside of image. What is here? I will go back to it. Okay. Let's see. I have some irregularity here, but it is along the crease of the skin. And in the real exam, they should bring two views at least to make sure that you are not missing any real abnormalities, and double check the terminal tufts. There is some There is some subtle fractures in the terminal tufts. Also, if they bring the oblique or lateral views, check for avulsion fractures. Here I'm checking the cortex. The cortex. See when I zoom, there is a cortical break here. So I will put it as mandible fracture, or we can put midline or symphysis menti to make sure that you put the exact site. And I will start by the edge of the film, femur, and then tibia. And there is some lucencies here, but I think they may be the vascular lines. Also, let's make the window a little bit bright. And don't forget the edge of the film. Sometimes the fractures are here in the metatarsals. Okay, so only this line. I think if they include another, if they include another view, it will be nice. But there is nothing there. Only this recency that I doubted. I don't know it is real or not. Uh, I think if I am not sure, better not to put it and keep it as normal. If you miss an image, it is okay, or even two images, it is okay. But if you use to overcall everything, you may probably get 4 or 5 images wrong. So better to be in the safe side. See, don't miss the pedicles again. And the outer ring, the inner ring, everything is okay. Sacral arcs, there is no calcifications here or there, so I put it as normal. Tibia fibula, teres calcaneum, and this again is parallel, and the other metatarsals are overlapping, so I will not see them. They are normal, and I think the last one we answered it. Let's go back to the abdomen. I think this one, he told as pneumoperitoneum, but really I don't know where it is. Hmm. There is sure signs as that free triangle of gas in the subhepatic area, a regular sign in a peripheral sighted bowel loops. Mm, maybe he mean this part, but really I am not so sure also because sometimes there is overlapping shadows and there is no other signs, sure signs. There is no bowel dilatation even. I think so. There is no pneumoperitoneum. Yeah, I think also like that. So, as a general advice, try to memorize the checklist and keep it in the same order and check the view because each view has its own checklist. Try to solve the exams like what I showed you. We took some time because of the discussion and clarifications, but try to solve to make the first run in 10 minutes, 15 minutes at most, without zooming, without windowing, without anything. Put only uh, the most abnormal things or the most clear abnormalities, and then go through the rest of the images by a little bit zooming, by a little bit windowing, and always check stick to the signs. If there is a definite sign for abnormality, so put it as abnormal. Don't put anything you are hesitated in it, or you are in doubt it is normal, or you need to justify why it is abnormal, or you need another view or another modality to make sure it is abnormal or not. At this time, the rapid reporting section is like that. Clear abnormalities, only short answers like what I showed you, side, cite, and sort, and that's it. Okay. If you have any questions, ask me now or post in the messages. You told me I need to share the PDF in the Telegram group. Also, put a message in the Telegram group to remind me. Sometimes I miss that or I forget to send it. So we have,
سؤال بعد إذن حضرتك.
yes.
أحيانا بيبقى فيه اوفرلاب متقاربز أو فالانجيس، وفي فعلا فراكشن واحد فيهم ودايما بقى يعني لما أجي أحل دايما يطلع غلط، يعني مثلا أكتب
The
تيست يطلع صفر، بيبقوا اوفرلاب فعلا.
they provided you only with lateral images.
أيوه.
Without AP, but not. This is not the situation in the real exam. In the real exam, they have to bring at least two views. Sometimes they bring three views or four views even, and so double check with the numbers from the other views and make sure that you put the exact and correct number, because if you put it as third finger middle phalanx fracture and it is the second, so the answer will be wrong. So
يعني هو
make sure
لو
that you put, yeah, make sure
في
that
الامتحان مش
you
هيجي بس
put,
وان فيو
yeah,
يعني.
one view only will not come in the exam. Yes.
تمام،
Sir,
شكرا.
can you please tell about signs of radial neck? Uh, Radial neck fracture. Sometimes difficult to get them. The best thing is like what I told you, to bring at least 10 images for this abnormality and train your eyes on it. Always the fracture is black, is sharp, reaching the cortex. The cortex will not be smooth, will be there is cortical defect. And try to train your eyes, see as much as you can for these images, for this single abnormality. The femoral neck fracture, do we mention the subtypes? I think for the level of the exams, for the level of the rapid exam, they accept radial femoral neck fracture. They accept this general term without putting the sub fracture, the subsite or the exact site. It is subcapital or intertrochanteric or like that. They accept the femoral neck as a general term, like what I told you in the Salter Harris as example. But you have to describe it. You have to describe if the fracture including the epiphysis or not, the metaphysis is included or not, reaching the articular surface or not. You should describe it very well. For Galeazzi or Montigia, you should describe the fracture is in bone named that, like that, and the dislocation is in blah blah. So you should describe everything in details. Kindly, if possible, PDF for emergency. If we encounter lytic lesion in the bones, should we just lytic? Yeah, just lytic lesion also is accepted answer. In rapid, because there is no discussion, you don't have history, you don't have anything other than the image in front of you. So they accept this general answers and make sure if there is pathological fracture included also or not. Okay. Is it okay to use the keyboard for the windowing, zooming, pan, or pressing? Yeah, you can use the letters or you can use the mouse. The letters, I think they are active. Yeah. If we are given single hand or foot, do we mention the site? No, never mention anything not included in the image. If they didn't put the site, so never mention the site. Okay, even in Viva also. Do we mention displaced, non-displaced, intra-articular? Yeah, you have to mention it. Intra-articular, you have to mention it. But other than that, you can mention as fracture only. But you have to mention the exact site. Don't put radial fracture. If it is distal, so you must put distal radial fracture, the exact site. Can we invert the image to look for pneumothorax or confirmation? The invert, uh, I don't know the invert option is included or not. Uh, I cannot remember. I even I don't know in the practice platform there is invert or not. Cannot remember really. Was in the RCR. You know the RCR put where is the exams? Oh, this is not our RCR. Sorry, RCR dot AC dot UK. Do I have to write the word finger or two? When yes, you must. You must put it finger or two. It is in your yeah. If it is included in the image windowing options to invert, and you are familiar with it, you can use it easily. Yeah, especially in fractures. Oh, it was long time to see the website. This is the videos. Yeah, try to see the practice by yourself also and use it. Uh, where is the, yeah, this is the rapid reporting demo. Enter. I am very confused about humeral and radial head neck. How do we characterize them? You want to differentiate between the head and the neck. I think for the head and the neck, it is clear. If the fracture is in the head, put as head. If it is in the neck, put as neck. Uh, I think it should be clear. Uh, Radial. Yes. See, the head is the upper part of the image is the head. The neck is this uh, short. See, this is the head. If the fracture is in the head, put the head. If it is in the neck, put the neck. Think as simple as that. See where is the fracture and put the exact site of it. Also, the greater tubercle fracture included in the head or the neck. The greater tuberosity. Yes. What is the problem in that? If it is fractured, you can put it. Yeah. Do you have any other questions? Where is the rapid reporting demo? Enter the exam pen. What was the exam pen? Can we instead mention number of digits? Uh, yes, you must include the number of the if there is a middle phalangeal middle phalanx fracture of the middle finger. So you must tell that right or left, middle finger, middle phalanx fracture. You must mention the finger or the toe that has the fracture. You don't require an exam pen. Why do you require exam pen? Ah, okay. Any other questions? Please solve by your hands. solve in a specific time manner. Where is uh, window measure ellipse? Yeah, I don't see the option of invert image. I don't see it. You may make it by your own hands like that. But it is difficult really. Without the option to be here, it is difficult. Okay. Try to train yourself on the Practique or any other platforms that is similar to Practique. Solve by your hands in a specific time manner. Memorize the checklist and train. This all what you need for this exam. The knowledge, most of the knowledge you already know about it. So don't waste more time in reading books or watching videos. Yeah, you will need some of them as well, but put much more time or much more effort in practicing active training. Okay, I hope you enjoyed the session. It was a little bit longer, sorry for that, but and please keep chatting on the Telegram group, asking whatever you want, and I am in your service. I wish you all good luck, and thank you.